on clinical cases of glaucoma, and I thought of having it in some sort of questions, and I tried to prepare it the same way you have it in the exam, in the form of MCQ questions, and in the same time clinically related. Excuse me, Ahmed, projector is not working. Okay, I think this lecture will be essentially based on you, so you are the ones who are going to exactly do the lectures. You will answer the questions one by one. Excuse me for doing that, but I think it's a very nice case of having an overview after. I'm sure you all studied glaucoma and you don't need a formal lecture or a systematized lecture now. So we will start. By Dr. Iqbal. The first question, you will take it. You will take the first question. We have 4 optic disc appearances, and you can just have a look to the optic disc appearances. This is the first one. Second, this is a stereo slide, it's 1 disc, and this is the 4th. And these glaucoma discs are more likely to be seen in this collection. You can have all these collections in chronic angle closure glaucoma, أنا عايز ترجع ورا خليها على الأول سلايد, or exfoliative glaucoma, which is true or false. These discs can be seen in chronic angle closure glaucoma.
Yes, true.
True. But is it more likely to be seen in chronic angle closure glaucoma? You can see it. We have Dr. Iqbal. So it's
all these.
Just focus on the question. You can have these discs in chronic angle closure glaucoma. Yes, true. You can have it in exfoliative glaucoma. Yes, true. You can have it in pigmented glaucoma. But these collections of discs, you just start to see what are these discs. This disc is a typical, a wide inferior notch. Is that right?
Yes.
You can see here this wide inferior notch. This disc is typical, having what here? What do you see here in this disc? Disc hemorrhage. Just a second, don't rush. So we have another disc. One disc has a focal change, the other one has splinter hemorrhage. This disc, what does it have? Yes, that's what we call it. We don't say pit. This is a bit. It's an acquired bit. Sorry? This is a pathognomonic feature of glaucoma. This is not a congenital bit. This is an acquired bit, which is pathognomonic for glaucoma. So you will see in the next slide, or in some slide other, the difference between this bit and the congenital bit. Okay? Yeah.
Can you say that the second one from the left, that the parapapillary changes is also related to the glaucoma changes?
Sure. But I will not say it is pathognomonic or highly suggestive, but it occurs. And so the third disc is acquired bit of the optic nerve. How about the 4th disc, which is the first one actually? Shallow, that's shallow cup. A disc with a very shallow cup, diffusely pale disc, have a characteristic PBA or peripapillary atrophy all around. Actually, you can see the 2 zones of the peripapillary atrophy. This is zone beta and this is zone alpha. And this actually is called senile sclerotic disc. This disc is usually has pale disc. It's not deeply cupped, it's just shallow cup, and has a characteristic peripapillary atrophy all around. I just say shallow. Look at this. Look at this blood vessel and go with it, and just a very slow slope here. And also the same way here. You can start here with a small slope. And this area, here it is. So you just say that it's characteristic feature of a disc, we call it senile sclerotic disc. When you look at these 4 types of disc damage, they are usually seen in glaucoma with some sort of ischemic disorder, which is more likely to be low tension glaucoma. Okay, so yes, it is true that we can see these changes in open angle glaucoma with high tension type, and also we can see it in exfoliative glaucoma. We may not be able to see it in pigmentary glaucoma, since pigmentary glaucoma occurs in young and you may not find this change, but they are more likely to be seen in low tension primary open angle glaucoma. Okay? Okay, Doctora? True or false? Start with. I wanted to just think in everyone. First think in the picture. What is this? And then start. This is the way to answer in the exam. Don't rush to the questions. Don't rush to everything. Look at the picture first and see, oh, this photo illustrates so and so. Most probably it will be so, and then you'll start to. So this photo. What is the diagnostic feature of this photo? Good, but actually it's not very shallow. You can see this deepening of the vessel, and you can see this also how it comes, and this one, and this is a wide cup. I will not say it's a small cup. Look at this deepening vessel here, but more characteristic is yes, that's right. So this is a cupped disc, which means a glaucomatous disc with splinter hemorrhage. So let's go to the first question. What splinter hemorrhage means for us? If this patient has uncontrolled glaucoma?
Yes.
That's right. Splinter hemorrhage or disc-shaped hemorrhages are one of the indicators for that this glaucoma is pretty much uncontrolled. Okay, so this is true. The disc suffers vascular insufficiency from high pressure rather than chronic ischemia. False or true?
True.
True. Is disc hemorrhage? No, I say suffers vascular insufficiency from high pressure or chronic ischemia. Is the insufficiency in the circulatory that's good. This laser? I mean that this disc hemorrhage occurs because there is some sort of vascular insufficiency in the circulation of the optic disc. This vascular insufficiency caused by ischemia of the disc due to other factors which we don't want to go through, or due to high pressure causing pressure on the disc. I mean, what is the mechanism of disc hemorrhage in glaucoma? That's the question. It just gives you an idea about what is the mechanism. The mechanism of disc hemorrhage is just ischemia. It's not pressure. Okay, it's one of the main supporters for low tension glaucoma is that there is high incidence of disc hemorrhage in low tension glaucoma, and it means that the vascular mechanism in low tension glaucoma is more than the pressure mechanism. So this is the third question. The second, how about disc hemorrhage occurs once and usually it appears in 1 to 3 months?
It can occur not only once.
Great. It's a recurrent process. Okay, that's right. But it is true that it disappears in 1 to 3 months. Okay, so this is false. How about in few months from now, this cup is expected to be large in all meridia? True or false?
False. Mainly oval it will be vertical.
It's false. It's right. Usually disc hemorrhage is followed by some sort of focal damage to the optic disc in the form of focal notch. So it will not be vertical as you see, but it will be there's focal notching, either inferior or superior. So if this disc is inferior, you will expect a focal notching in this area. And in the visual field, you will expect an upper dense paracentral scotoma or upper nasal step in this area. So usually disc hemorrhage is followed by focal notching of the optic disc. Okay, how about this plaque? This black and white fundus photography is recommended in the follow-up.
Yes.
Why?
Neck fiber layer.
Great. That's right. Also, the same thing. Disc hemorrhage predicts or precedes localized nerve fiber defects, especially wedge-shaped defects. So most probably, even if this patient in a few months from now and the hemorrhage has appeared, you can do black and white fundus photography and you can detect a wedge-shaped defect. Okay?
And because there is no sport at the edge of this cup, that's why the hemorrhage is there splinter in this case.
Sorry, again?
I mean, if there's no sport at the edge of this cup, so that's why there is a hemorrhage.
I still don't understand. What's no sport? No what?
I mean, the cause of the hemorrhage, particularly the slow.
Okay, let's talk about disc hemorrhage a little bit. Disc hemorrhage usually occurs, it's called, some people call it Drance hemorrhage because Steve Drance is the first one who discovered this. Disc hemorrhage in a form of splinter-shaped hemorrhage. It doesn't occur like a plot hemorrhage or dot hemorrhage or something like that, because it follows in the superficial layers of the optic disc. And usually it does not occur in the cupped area. It occurs along the neuroretinal rim area and usually extends across the edge of the optic disc. So it spills over like here. Yeah, you can see it here and also extending a little, spills over the optic disc. And it goes in the differential diagnosis of many things. So any diabetic patient, any ischemic optic, CRVO or whatever, you can have it in the differential diagnosis. But still, disc hemorrhage has this unique characteristic in glaucoma is that it's fleeting thing. So it appears if you can just pick it. Once you see it, send the patient directly to the photography to document it. Okay, and as we said, it's mainly caused by vascular insufficiency from ischemia. Some people say, and these are the opponents of the pressure theory, say that the high pressure causes some sort of shearing effect. It shears the capillaries at the optic disc and can produce the hemorrhage. But still, because it's present more in low tension than in high tension glaucoma, they still consider it a vascular mechanism. Disc hemorrhage has a characteristic finding that it's recurrent, and usually it occurs on the side of uncontrolled glaucoma and more in low tension, as we said. And even in low tension glaucoma patients, they found it to be more in the eye with the high pressure, with the low tension, high pressure. It means that if you have a low tension patient with a pressure usually in the 18th or 19th, and another patient with a pressure in the 14th, disc hemorrhage is more likely to be in the patient with the 18th. Okay? All right. Sure.
What would be considered the greatest risk factors in predicting primary open-angle glaucoma in a white population?
I'm sorry for getting these few questions because they are epidemiological, but it's related to primary open-angle glaucoma, and these are the kind of questions you usually miss in the exam. These epidemiological and statistical questions, I know. So think about.
A brother diagnosed with glaucoma, a parent diagnosed with glaucoma is true. An aunt diagnosed with glaucoma,
It's true also. Yeah, because you rely your answers on just the family history. No, think about the question, what is the greatest? So he needs only one. One answer is true.
the greatest.
Yes. So it's only one answer is true.
A parent.
A parent diagnosed with glaucoma. A spouse.
This is the parents, because because of the family history.
Family history gives you parents. Actually, it's false. False. Brother, that's right. Brother diagnosed with glaucoma is the greatest factor that can predict open-angle glaucoma. And in epidemiological studies, they found that first-degree relatives have odds ratio which is higher than the parents, and which means that brother have a higher ratio to get glaucoma than a parent. Okay. So. Hello?
Which of the following patients is at the highest risk for developing glaucoma? 74-year-old. Have you one answer or true or false?
The same.
Highest risk. 74-year-old white man, 74-year-old white woman, 74-year-old black woman, black man. 74-year-old white woman with a spouse diagnosed black. 74-year-old with a black man.
74-year-old black man. True. That's true. Yes, that's right. We have here three factors: age, sex, and race. So age is a constant factor here, but we all know that the older, the higher incidence of glaucoma. And we know the incidence even up to 80 or 90 years, you can have a 10% incidence of glaucoma. Okay, even 15% incidence of glaucoma. So age, all have higher incidence of glaucoma. Sex, males or females? Well,
In chronic angle closure, it's more female, white.
mhm.
But in the
Chronic angle closure, white females.
But they are blackish.
Right. Females have higher incidence of acute angle closure. Acute angle closure, not chronic. So females have incidence of acute angle closure higher, even 4 times higher than males. But in primary open angle glaucoma, males are more affected than females, especially in the older age group, above 70. So these are some epidemiological factors. Above 70, with older age groups, they found males to have higher prevalence of glaucoma than females. And the race, we all know that black race have a higher incidence of glaucoma, primary open angle glaucoma, than whites or other races. And there's also the possibility to get blind from glaucoma is much higher in blacks than in whites. Okay?
The uncontrollable glaucoma is higher in blacks than.
And that glaucoma is less likely to be controlled with the usual medications. That's right. Okay? Muhammad?
Which of the following risk factors for glaucoma has the highest predictive value for developing primary open-angle glaucoma? Sibling with primary open-angle glaucoma, African descent, Caucasian race, father with glaucoma, grandfather with glaucoma. I think B and D. B or D.
B or D? Just one answer. There are some questions you will have many answers, many true or many falses, but this one needs one answer. Okay, D. No, it's false. A is true. A is true. Yes, A is true, because also I didn't tell you that the odds ratio in the I think Framingham study or Beaver Dam study in Australia found that in this order, the odds ratio for predicting glaucoma was first sibling with glaucoma, again the first degree relative, and then the parents. In this order, it's about 3.9, and then 2.7, and then 1.3. And this is the order. So a sibling with primary open-angle glaucoma is the highest factor to predict primary open-angle glaucoma. Yes. The first, and then the first degree relatives as brothers, and then the parents. Okay? Okay, doctor?
Which is more likely to develop primary open-angle glaucoma? Asian, white, Hispanic, black, mixed age. Black.
Okay, we just discussed this. Okay, Ramez? Okay, we guys still talk about primary open angle. Okay, so we now think about a patient who has primary open angle glaucoma, or yeah, we didn't diagnose, or we have the patient in the first time. We think he has a primary open angle glaucoma. One of these 5 patients, and we just sit in front of the patient and think about, shall we treat this patient or shall we don't? Okay, so if you have a patient who is 80 years old and he's white and a female and has normal intraocular pressure, okay, and vertical enlargement, has a vertical enlargement of the cup with asymmetry of the rim, this patient shall we treat or we don't, should not? Just asymmetry. You only have the paper in front of you. You don't talk to anyone. This patient sitting in front of you, you will give him visual field as it is. You don't know anything about the visual field. It's just this criteria. Based on this criteria, shall we treat or we don't? Based on what? Age?
And the cup characteristic.
Cup asymmetry.
Yes.
With vertical
With vertical enlargement.
Yes, vertical enlargement.
3 risk factors.
That's the most diagnostic feature. There is vertical enlargement. So you will not say that this is the physiological cup. Okay? So this patient most probably has low tension glaucoma and needs to start treatment. Is that right? Okay. How about a patient who is just 35 years old and a female, IOP between 25 and 30, and 0.6 cup disc ratio in both eyes?
No.
You will not. This patient will be considered ocular hypertension. So this patient, you will go to do some work up for him, visual field and disc photo and nerve fiber analysis and so. Okay? How about a 40 years old white woman with an IOP of 25 and 0.6 cup plus a grandfather with glaucoma? You will treat. What's the difference between this patient and the second patient? Just the family history? Okay.